Hello students, I'm the OGGuru Dr. Punit Bhojani and welcome to the session. Here we are going to discuss the top 10 PYQs for the upcoming FMGE examination. But before that, I would like to tell all of you to download the OGGuru app and all of you can go for 1 month package. We have launched the masterclass package which is available only at 798 rupees. This includes all the previous year's questions, rapid revision MCQ, beautiful handwritten notes, all theoretical concept, mock test, and of course my timetable and guidance. So I request all of you to go for this masterclass, 1 month duration, and all of you will be able to revise the entire OBGY in few days time under my guidance. Okay, so now let us go on to the top 10 MCQs. And the first question, Fothergill's repair is associated with all of the following complications except. Now anybody, point number 1, what is this Fothergill surgery for? So Fothergill surgery is for prolapse uterus. Okay, it's for prolapse uterus. And please understand, we should know how you will know the complication when we know what is the main step. So can anybody tell me what is the main step in Fothergill surgery? The main step of Fothergill surgery is cervical amputation. Okay, so this is almost like a outdated surgery and therefore I'll tell you what is preferred. So cervical amputation, that means the cervix is what was done is that this is the uterus, this is the cervix, and we chop off the cervix. Cervical amputation is the main step of Fothergill operation. Now it was done for young patients of prolapse. Now why we don't do it nowadays, you will come to know. So in the olden days, this surgery was preferred for young patients of prolapse, where they said that we'll chop off the cervix and the uterus will remain and will create a new cervix. Now what used to happen was that when you amputate the cervix, what can happen? Sir, when I amputate the cervix, what can happen is either the cervix can become too tight. So there is a risk of cervical stenosis. Cervical stenosis can happen and this cervical stenosis can cause infertility. Okay, so patient is not able to conceive. There's infertility. There could be cervical dystocia. During labor, the cervix does not dilate. And the other complication is cervical incompetence. And as all of you know, or all of you should know, that cervical incompetence, if it happens, then when will the abortion take place? Yes, cervical incompetence will always cause abortion in the second trimester. Okay, so cervical incompetence would lead to, yes, and the important word, painless second trimester abortion. And it is also recurrent if you don't treat it. So recurrent painless mid-trimester abortion, or the cervix becomes too loose, there's a risk of preterm labor. So can the infertility take place? Yes, sir. Cervical stenosis can lead to infertility. It can also lead to cervical dystocia. What is this word, cervical dystocia? That means during labor, the uterus is contracting but the cervix fails to dilate. So I repeat, okay, sir, because of this cervical amputation, the problem is either the cervix becomes too tight, which is cervical stenosis, which could lead to infertility and cervical dystocia, or the other complication of this cervical incompetence is cervical amputation is the cervical incompetence, which would lead to repeated mid-trimester abortion, and also of course there is a chance of even preterm labor. Okay, so preterm labor can also happen. So now I know, can infertility take place? Yes, because cervical mucus is also important for sperm capacitation. Preterm labor, yes, and the answer is because it is all except first trimester abortion. No, first trimester abortion, the causes are completely different. It could be genetic causes, chromosomal problem, uncontrolled over diabetes, all that would cause first trimester abortion. So first trimester abortion नहीं होता है सर, simple Fothergill operation, main step is cervical amputation, जिससे हो सकता है cervical incompetence. And cervical incompetence, if it happens, there is going to be repeated painless second trimester abortion and not first trimester. And by the way, can anybody tell me what is the treatment of this cervical incompetence? Yes, the encerclage operation. Okay, that's just by the way. And therefore, my dear students, for this so many complications, as you know, okay, there's so many complications, including even hemorrhage, Fothergill surgery is not done nowadays. And can anybody tell me, therefore, what is preferred? What is preferred for young patient of prolapse? What is preferred? Yes, many years back, Akshay Kumar movie had come, Sing is King. Yes or no, Sing is King? Yes. So all of you will remember, Sling is King. Sling is King का मतलब है कि sling surgery. All of you write down, Sling is King. So sling is king का मतलब है sling is the best. Therefore, for young patients of prolapse, a sling surgery or cervicopexy. Sling surgery, another name is cervicopexy. So remember, students, that you will never ever mark Fothergill surgery for young patients of prolapse because of so many complications, and sling is king or sling is the best surgery for young patients with prolapse operation. Okay, moving on to the next MCQ. This device, anybody identify this device? And the question is, it is least likely to be used for. Now, what is this device? Anybody? Yes, sir. This is the uterine sound. Okay, this is the uterine sound, to sound the uterus and to measure the uterocervical length. So basically, what does this instrument do? You can see there's a bend over here. This instrument measures the UCL, uterocervical length. This sound also acts like the first dilator. So always we sound the uterus. And why is it important to sound the uterus? So that I know it is like this. Okay, so I will put the sound instrument through the cervix, and then I will come to know like this. Let's suppose this is the uterus, this is the uterus, then the instrument will go till here. So I have measured the uterocervical length, and then the subsequent instruments which we put inside the uterus, we should never go beyond this. Otherwise what will happen? You will, yes, आप extra अंदर घुसा दोगे instrument तो perforation. So you measure the UCL so that we know that we don't perforate the uterus. So basically, uterine sound is for all procedures where some intra-uterine manipulation or intra-uterine instrumentation करना है, तो उसके पहले we always measure the UCL. So कहाँ पे? Yes sir, dilator. I need to put the dilator. So I cannot put too much dilator inside. So DNC, yes. Suction evacuation, also yes, I put that suction cannula. And similarly, IUCD insertion also. Otherwise, if you put too much of your IUCD plunger inside, again perforation. So basically, the instrument is uterine sound. It helps us to measure the uterocervical length. And common sense, the question is, this device is least likely. So the answer is removal of IUCD. How do I remove the IUCD? All of you know, sir, if this is the uterus, this is the uterus, and this is the copper T or the IUCD, there are threads. So directly we pull this thread out with the help of artery forceps. So while removing the IUCD, sound is not required. Sound is not required. Uterine sound is not required in removal of IUCD. Is this understood to all of you? So the question is this, again a very famous PYQ, at least likely for removing of IUCD. So DNC, yes, because I want to put a dilator inside. Suction evacuation, IUCD insertion, all these cases we are going to measure the UCL and then do the procedure. So ABC, I will definitely use the sound. Removal of IUCD, we just hold the threads. Sound is not required. The threads at the end of the copper T are just held with the instrument artery forceps, and you just pull the IUCD out. Okay, moving on to the next MCQ. Which of the following is an indication for surgical management of ectopic pregnancy? Okay, so the question is that where I will have to go for surgical management, matlab basically where the medical management is not possible. So all of us should know that medical management is the preferred treatment for ectopic pregnancy wherever possible. And what is that medical management? Yes, methotrexate. Methotrexate we give intramuscular injection, and that is the preferred management for ectopic pregnancy wherever possible. And there are certain criterias. What criterias have to be fulfilled for methotrexate? All of you should know by heart. Okay, so basically please understand, when will I give methotrexate? Common sense, the patient should be stable, isn't it? Ruptured ectopic, patient in shock, I will not give methotrexate. Common sense. So basically it can only be given for unruptured ectopic pregnancy. Unruptured ectopic, that means the patient should be, I am writing HD. HD matlab hemodynamic stable. Okay, now second thing is that when I do the sonography, the gestational sac on the sonography should be less than 4 centimeter. So with this MCQ, we are also discussing the medical management and surgical management of ectopic. So G-sec should be less than 4 centimeter as you measured on ultrasonography. And very important, the beta HC level should be less than 5000 micro international units per ml. At your level, even if you remember these 3 conditions, remember students that if these 3 conditions are fulfilled, we can go for methotrexate. And preferably at your level, also remember that the fetal cardiac activity should be absent. That means it should not be a live ectopic. The fetal cardiac activity should be absent. Is it clear? So if all these criteria are fulfilled in the question paper, all the 4, superb. But if not at least first 3, then please understand methotrexate will be the answer. But now the question over here is that in which of the following I will go for surgical management. Matlab basically where the methotrexate is not possible, where MTX is not possible. So the HCG level less than 1000, yes, I will give methotrexate. Unruptured ectopic, of course, yes, I will give methotrexate or patient stable. Patient wants to continue pregnancy, okay, ectopic patient cannot continue pregnancy. You have to explain the patient. Okay, ectopic will rupture, and ectopic will grow and rupture. It will be blast. It's a life-threatening condition. So patient wants to continue pregnancy is a stupid option. Patient cannot continue ectopic. So यहाँ पे it's neither medical nor surgical. This option is given just like that to confuse the student. Basically, clearly, yes, sir. If the gestational sac size, if the size is more than 4 centimeter, which I told you, some say 3.5, some say 4, that's okay. What was the criteria I told you? The question for methotrexate or medical management. Methotrexate is the medical management. Gestational sac should be less than 4 centimeter. So the question here is in which of the following is the indication for surgical management? The first option. Is it clear, students? Okay, the gestational sac size is more than 4 centimeter. Methotrexate will not work and I will have to go in for surgery. Beta HC less than 1000. Of course, methotrexate I will give. Unruptured ectopic also I will give methotrexate. Okay, so the question is where the methotrexate is not going to be helpful to us is option number 1. Methotrexate will not work. I will have to go for surgical compulsory. And one more thing, after giving methotrexate, how do I know my success? How do I know my treatment is working or not? Yes, we need to monitor the HCG, and the HCG levels after giving methotrexate should keep on decreasing. That means the treatment is working. Okay, moving on to the next very important MCQ. Yes, this is a very confusing topic. Many students do not know. I request you to go and see the whole video. RH negative lady is there. She is undergoing an abortion or an MTP at 11 weeks. What is the dose of anti-D? Now please understand this. Here it is assumed that when the patient is RH negative, she is married to a RH positive husband. Okay, so the father or the partner is RH positive. Okay. Okay, so husband or the partner is RH positive is understood. The lady is RH negative. So I've got a RH negative female and RH positive partner. And one very important point, my dear students. Okay, the anti-D role. What is the role of anti-D? Is to prevent the antibody formation. If the antibody is already present, then anti-D is useless. Okay, so I want all of you to remember like this. It's sir, if the antibody, okay, if the antibody is already present, then anti-D no role, anti-D no role. Okay, there is no point giving anti-D injection. That means anti-D is useless. Write useless so that you remember the words. Okay, anti-D no role if the antibody is already present. And how do I know in a patient if this antibody is already present or not? By doing ICT, indirect Coombs test. So remember student, that when I want to give the anti-D injection, when we want to give the anti-D injection, remember that the ICT should always be negative. ICT should always be negative. Then only there is a point of giving the anti-D injection. Is this understood to all of you? Because if the antibody is positive, that means if the indirectly the ICT is positive. Okay, student, indirect Coombs test is positive means that the antibody is already present, and then the anti-D is useless or there is no role. Okay, so in a Rh negative woman, husband, so mother is Rh negative, the father is Rh positive, and ICT has to be negative. Now remember, after delivery, 300 microgram is given after the birth of the baby, after delivery. Okay, after delivery or anything in the second trimester ruptured ectopic, second trimester MTP, then 300 microgram is given after delivery. But after delivery, we do the baby's blood group. So after delivery of a Rh positive baby, okay, common sense, if the mother is Rh negative and the baby is born is also Rh negative, फिर मदर को एंटीडी का जरूरत नहीं है क्योंकि नेगेटिव ब्लड नेगेटिव में गया, कोई प्रॉब्लम नहीं है. सो आफ्टर डिलीवरी ऑफ अ RH पॉजिटिव बेबी, then how much dose I will give? 300 microgram. But the question over here is, we are only in the first trimester. So this is on the assumption. Please understand, sir, why we give anti-D? Many students don't know. We give anti-D because prevention is better than cure. Now common sense, this abortion which happens at 11 weeks, okay, can I find out that baby's blood group? No. After delivery of a baby, I can do the baby's blood group. Barabar? But that MTP what happens, or ectopic what happens, it is not possible to find out the baby's blood group, and therefore we assume that the baby is Rh positive. So this anti-D injection is given on the assumption that with this abortion or MTP, whichever happened, that baby or the fetus was Rh positive. And anything in the first trimester, the dose is 50 microgram. Very difficult MCQ. Please don't make a mistake, likely to be repeated. I repeat that anything in the first trimester, either first trimester MTP, so either if it's a first trimester abortion, spontaneous abortion, or MTP, first matlab first trimester, or even ectopic pregnancy, the dose is only 50 microgram. Anything to do afterwards, okay, like the second trimester MTP or after delivery, then it is 300 microgram. Only thing, after delivery, we can do the baby's blood groups after delivery of a Rh positive baby. So remember, mother should be Rh negative, father should be Rh positive, ICT should be negative, then only anti-D has a role, and 50 microgram for anything in the first trimester, 300 microgram after birth of a Rh positive baby. Moving on to the next MCQ. Patient complains of severe abdominal pain and ovarian torsion is suspected. Next best investigation is what? So whenever there's a ovarian torsion, the severe pain, vomiting, and we want to look at the blood supply, because what will happen is that when the pedicle will twist, when the ovarian torsion, when there's a twist, then the blood supply will get compromised and that part can start undergoing necrosis. So basically remember that torsion ke liye we are interested to find out that if the blood flow is maintained, then there is no torsion. Or when there's a twist, common sense अगर आपका ऐसा twist हो जाएगा तो vessel kink हो जाएगा and the blood supply will be compromised. And anybody out of all the following, sorry, CT scan say I will only know the ovarian mass. Similarly, MRI cell come to the mass, whether that ovarian tumor, how big, how small it is. But whenever I want to look at the color, at the blood supply, remember color Doppler. That's even in surgery. Lower limb DVT, color Doppler. IUGR, color Doppler. Anything to do with the blood supply or the blood flow, we are going to we have to look at the color Doppler, and that is the answer. So CT scan, MRI will only, or even USG, plain USG will only tell me about the ovarian mass, but for torsion specifically color Doppler, that's yes, USG color Doppler. Ultrasonography ke saath you do the color Doppler. That is the next best investigation. Okay, hysteroscopy has nothing to do with the ovarian torsion. Hysteroscopy is to look at the uterine cavity of the uterus. Okay, we are going to look at the cavity of the uterus with the hysteroscopy. Moving on to the next MCQ, but do not forget to hit the like button, share the video with your friends, and do subscribe to the channel if you already haven't subscribed yet. Okay, very important clinical case scenario. What is the diagnosis? Primary gravida, 31 weeks, complaints of headache, blurring of vision, oliguria, BP 180, 110, albumin plus 4. Can somebody tell me the diagnosis? Yes, not only preeclampsia. Why preeclampsia? Because BP is 180, 110, albumin plus 4. But what more? Can anybody tell me? Yes, sir. There are certain dangerous signs and symptoms which are called as the premonitory symptoms. What are those? Headache, blurring of vision, oliguria, and two more which could be present could be nausea, vomiting, and epigastric pain. This 5 all of us should know by heart. What are the 5 dangerous symptoms? Headache, blurring of vision, oliguria, nausea, vomiting, epigastric pain. Then this, and along with severe preeclampsia, what is the diagnosis? Yes, sir, it is impending eclampsia. Patient has not yet got convulsion. Convulsion is not mentioned in the question paper, but it is impending eclampsia. It means abhi kabhi bhi convulsion aa sakta hai. Now what do we do? Anybody? So please understand, आपने हिंदी मूवी में देखा होगा या बाकी रीजनल लैंग्वेज मूवी में देखा होगा, डॉक्टर कम्स आउट ऑफ द लेबर वार्ड एंड सेज हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Have you heard this dialogue before? Yes. Please understand कि this kind of option is never ever given to the relatives. क्यों? क्योंकि कोई बोलेगा माँ को बचाओ, कोई बोलेगा बच्चे को बचाओ, डॉक्टर बोलेगा सेव द इंटर्न, सेव द डॉक्टर, इंडियन गवर्नमेंट सेव द टाइगर, तो whom to save? Okay, so please understand this, that in obstetrics it is always mother first. Why? Because अगर mother है तो पीछे पूरा क्रिकेट टीम आ सकता है. It means if the mother you save, then she can give birth to as many babies as she wants afterwards. Why did I tell all this story is, okay, sir, in this question paper, we are only 31 weeks. Yes, still, please understand this, that whenever this impending eclampsia develops, whatever may be the weeks of gestation, let it be 31, 33, 35, or for that matter, 24, 26, 28, whatever may be the weeks of gestation given to you, we will not wait further. Sir, if a 31 weeks baby cannot survive, okay, no problem. I said माँ और बच्चे में से माँ को बचाना है, mother is more important. So if you have a situation which is 24, 26 weeks, yes, we know that the baby may not survive, still the answer will not change. And remember, dear students, that whether it is impending eclampsia or eclampsia, delivery is the definitive treatment. Delivery is the definitive treatment. But hold on, that's not the complete answer. So please understand, delivery is the definitive treatment, and the delivery has to be done irrespective of weeks of gestation. But before we do the delivery, we will also give very important magnesium sulfate. Now, can anybody tell me Why give magnesium sulfate over here? This patient has not got convulsion. Yes, this is prophylactic magnesium sulfate. It has been proven beyond doubts that when I give Maxelf, it will prevent convulsion, prevent eclampsia, prevent maternal mortality, prevent abruption. And again, remember students, once we give magnesium sulfate, you cannot say, now let me wait and watch. Sorry. Okay, sir, we are 24, 26 weeks. Let us give Maxelf and wait till, let us wait till 34 weeks. Sorry, that is not possible. So whenever this impending status is reached, never wait and watch. And once you give magnesium sulfate, yes, you are supposed to also do the delivery. And by that delivery, I mean we try vaginal delivery. We go for induction of labor. Okay, never directly do LSCS. You induce the labor first, and if induction fails or there's some problem, then you can think of doing LSCS or there's fetal distress. That's separate story. Okay, so please understand this. Now you look at it. Labetalol, yes, I would want to give, but wait and watch. Sorry, never wait and watch. Why? Because the mother will die. Okay, direct LSCS, never. Magnesium sulfate, very good. Labetalol, very good. But then deliver at 37. Will I do this? No. We are only 31 weeks. If I wait, baby, mother will die in that remaining time. So I never wait and watch. And the answer, magnesium sulfate, labetalol, and immediately induction of labor and delivery has to be done. And most important words coming in the bracket, delivery irrespective of weeks of gestation. Okay, or gestational age. So let the question paper be 30 weeks, 26 weeks, 28 weeks. If it is impending eclampsia, the answer is give Maxelf and delivery irrespective of weeks of gestation ke baaju mein please put 5 star. Similarly, the flow chart will not change. If it is actual eclampsia, also the same flow chart. We will give Maxelf and then immediately proceed for the delivery. So Maxelf is to prevent convulsion or to stop the convulsion, but the definitive treatment is delivery. Please don't make a mistake in this. Delivery is the definitive treatment. So please, we need to do the delivery, and therefore induction of labor has to be done. So it's a very important MCQ. Never wait and watch, and whatever may be the weeks of gestation, we in a case of impending eclampsia, we have to proceed for the delivery. Maxelf is given. Of course, labetalol will also be given. So Maxelf, labetalol, and induction of labor is the complete perfect answer. Clap if you have learned something new. And moving on now to the next MCQ. Hysteroscopy is done for all of the following except is the question. Now please understand this. Many students have a confusion. What is done exactly in hysteroscopy is that remember student, in hysteroscopy, I put in a telescope through the vagina into the cervix, and basically we are going to evaluate the uterine cavity. So remember students, hysteroscopy is to visualize the inside of the uterus, uterine cavity, not the outside of the uterus. Okay, if I want to evaluate the outside of the uterus and the tube, ovary, pouch of Douglas, all that, we use a laparoscopy. So in hysteroscopy, we are going to evaluate the uterine cavity, and any problem in the uterine cavity, we can see it and also simultaneously treat it and correct it. So example, if there are intrauterine adhesions, okay, so this is the hysteroscopy which we do. Suppose there are intrauterine adhesions, also called as what? Yes, Asherman syndrome. Or sir, there is a endometrial polyp. There's an endometrial polyp. Or sir, there is a submucosal fibroid. There's a fibroid which is protruding into the cavity of the uterus. Or there is a septum, septate uterus. All these conditions could be diagnosed with hysteroscopy, and not only for diagnosis, simultaneously we can do the treatment and the hysteroscopic surgery can be done. What can be done? All of you look on the board. I'm doing the surgery. You can cut the adhesions like this. So hysteroscopic adhesiolysis. You can cut the polyp, hysteroscopic polypectomy. You can cut the fibroid, hysteroscopic myomectomy, and you can cut the septum, hysteroscopic septal resection. Very important previous year question. Okay, so all of you know, okay, sir, for intrauterine adhesions, polyp, fibroid, septate uterus, all these conditions, the hysteroscopy is going to be helpful and useful. So Asherman syndrome, of course, yes, which is intrauterine adhesions. Of course, I told you that your endometrial polyp and submucosal fibroid are definitely going to cause menorrhagia. So in menorrhagia, also after you do the USG and all that, hysteroscopy will be required, and all these cases which I mentioned to you, fibroid, polyp, adhesions, are going to cause infertility also, and therefore for infertile patients also, to evaluate the uterine cavity, hysteroscopy is the most important and the best investigation. Obviously the answer is adenomyosis. Why, sir? What is adenomyosis? Yes, sir, for adenomyosis we are going to do USG or MRI. Adenomyosis is, sir, presence of endometrial glands within the myometrium. Okay, so that you're not going to see. Okay, the glands are within the myometrium. So usually we do a ultrasonography, if required even MRI. Okay, is this clear? So presence of this endometrial glands within the myometrium. Okay, so even if you know the definition, you know the MCQ, simple, no need to mug up के sir बाकी जो points है 1 2 3 is something to do with the cavity of the uterus. Adenomyosis within the myometrial wall, and therefore no role. Okay, and septum treatment also has been asked in the past. It is hysteroscopic. Okay, so please understand this, all this surgery we do is hysteroscopic surgery we do. So treatment of septate uterus, not laparoscopy, it is hysteroscopic septal resection. Moving on to the next MCQ. All of the following are used to deliver the after coming head of the breech except. Now see students, you may not know all maneuvers, but this kind of question you can solve easily if you just know, okay, where is the other maneuver used. So Burns-Marshall maneuver, yes sir, we use for after coming head. What it is that you allow the baby to deliver and the head is still inside the vagina, the mother is lying down over here, and what is done is, okay sir, you hold the baby by the lower limb and rotate it up towards the maternal abdomen. Okay, rotate the baby up. So as the baby moves up, this head will pop out from below. That is the Burns-Marshall maneuver. I'll give you a trick. What is this MSV maneuver? Morrissey smelly wheat. So remember students, in MS, you do MS. In MS, do MS. That means, sir, in Morrissey smelly wheat maneuver, that is in MS, what do? We put the left hand malar flexion and shoulder traction. So malar flexion is done. Malar flexion is done. And shoulder traction is done. Okay, is this understood? Anyway, how the maneuver? So this S is shoulder traction. Okay, M is malar flexion. So in MS, in Morrissey smelly maneuver, you do malar flexion plus shoulder traction. How the maneuver is to be done, nobody is going to ask you. You should just know the name. And similarly, there's the Wigard-Martin maneuver, which is also a combination, partly malar flexion, and then you give a suprapubic pressure, all that. Details you're not supposed to remember. Mac Roberts is the answer. Anybody? Very popular. Mac Roberts is what? It's a hip hyperflexion. You hyperflex the hip and abduct the hips onto the maternal abdomen. This is done for shoulder dystocia. So I think most of the students know, okay sir, the Mac Roberts maneuver is for shoulder dystocia. It's a very popular maneuver, and therefore if you know this, you know the answer. You may not know all the names. Most of the students know only Burns-Marshall maneuver, but then you know, okay sir, Mac Roberts surely is for shoulder dystocia. So MSV Wigard-Martin, even though new names, will be always for after coming head of the breech only. Okay, so Mac Roberts maneuver. So we give suprapubic pressure, that's the first maneuver, and then we do the Mac Roberts maneuver. So one of the very early maneuvers, or one of the initial maneuvers which we do for shoulder dystocia, Mac Roberts maneuver. Hip hyperflex the hip onto the maternal abdomen. Okay, so that's a very important MCQ. Names of the maneuver, at least these you should know. Moving on to the next MCQ, and clap if you have liked this in MS, do MS. As I said, please leave a comment, hit the like button, and do subscribe to the channel. Very important, which of the following is a absolute contraindication for IUCD or copper T? Okay, by the way, the another word, this is a simple MCQ, they can make it more difficult and they can say instead of absolute contraindication, they can use the word category 4. Okay, WHO category 4, WHO has put a category, and when you say category 4, it means nothing but absolute contraindication. So another name for absolute contraindication, my dear student, is category 4. So they can tell you category 4 for IUCD is what? Same answer. Okay, now please understand this past history of PID, not so much. Acute PID. Okay, if it's a acute pelvic inflammatory disease, I can never put a copper T. Okay, the poor copper T or IUCD has unnecessarily be blamed for ectopic pregnancy. No, IUCD as such does not increase the ectopic rate if you put it all properly with all aseptic precaution. So IUCD ka history also is not a contraindication for ectopic. If a patient has a ectopic pregnancy, you can still go ahead and put a IUCD, no problem. Menorrhagia, yes, you avoid, but menorrhagia and dysmenorrhea are relative contraindication, not absolute. Okay, remember, so menorrhagia and dysmenorrhea are a relative contraindication. Undiagnosed vaginal bleeding is the absolute contraindication. If you do not know where the bleeding is coming, so of course pregnancy, undiagnosed vaginal bleeding, acute PID, 2-3 more we should know. Which all cases? Okay, so we are talking for IUCD. So remember one thing, even your cavity, if it's a fibroids and the cavity is distorted, all of you can look on the board. If there's a fibroid here, fibroid here, fibroid here, fibroid here, how is the cavity become? So the cavity has become completely distorted and the copper T will not fit properly. Okay, so distorted cavity. Similarly, if the two horns, bicornuate uterus, okay, two horns, how will the copper T fit? Okay, which horn to put copper T? Okay, so remember acute PID. Similarly, your cervical cancer, endometrial cancer, undiagnosed vaginal bleeding, and very important, remember, after even a vesicular mole, suppose after suction evacuation of a vesicular mole, we avoid because uterus is very soft, there's a risk of perforation. Okay, so acute PID, puerperal sepsis, so any infection, okay, following a septic abortion, okay, so acute PID after vesicular mole suction evacuation, puerperal sepsis, undiagnosed vaginal bleeding, distorted cavity, and bicornuate uterus, genital tuberculosis, all that is my absolute contraindication along with undiagnosed vaginal bleeding and of course pregnancy. So all this, even if you know 3-4, pregnancy, acute PID, puerperal sepsis, undiagnosed vaginal bleeding, cancers of the endometrium, cervix, and your distorted cavity, okay, distorted cavity or double cavity, all this will become absolute contraindication. Remember, menorrhagia as well as dysmenorrhea, we will avoid a copper T. Here, in fact, your Mirena or LNG IUD can be used. Okay, but they have not said whether it's copper or LNG. But menorrhagia patients we treat with LNG IUD also. Okay, but menorrhagia, dysmenorrhea is a relative contraindication we avoid. Okay, so this is very important. Just keep these 3-4 points in mind and clap if you have learned something new. Absolute contraindication, another word is category 4 of WHO. Okay, moving on to the last image-based question. Very important. It's a popular MCQ. There is the infertility history and patient has been treated with ovulation induction. Only this picture will come actually in the exam, but it's an incomplete picture. Why? I will tell you, because along with this, they should also show you one more picture. So what is this you can see over here? Sir, we can see a big ovary, and what all we can see? Sir, we can see all big follicles. Okay, we are seeing, because moment student sees this follicle, they mark PCOS. Wrong. Okay, that's not the question. Okay, that's not these are multiple big follicles all coming in the center also. They're in the center also and they're everywhere. So this is ovarian hyperstimulation syndrome. Specifically, which ovulation induction agents? Clomiphene citrate very rarely, my dear students. HMG, human menopausal gonadotropin, or if recombinant FSH is used like in IVF, and along with it HCG. HCG is the main culprit. When you give HCG as a final trigger to maturate the egg for the final maturation, HCG is important in development of OHSS. So when this ovulation induction agents like HMG and recombinant FSH is used along with HCG, that is a risk factor for development of OHSS. But remember, PG level, that this kind of picture you can also get in a stimulated ovary. Along with it, there should be ascites. So actually when there is free fluid also, but they will give you only this one picture. So yes, we can mark OHSS. So when you get multiple follicles, but big follicles, okay? So they are big follicles, okay? I will show you how the PCOS also looks. So big follicles, when they are there inside the ovary, big bulky ovary, along with ascites or free fluid, that's your free fluid in the pouch of Douglas, that is the main picture for OHSS. Now PCOS, my dear students, please understand this. PCOS में क्या होता है? Multiple small follicles, okay? They are multiple small follicles arranged in the periphery of the ovary, okay? 12 or more than 12 follicles, 2 to 9 millimeter. So all this are, you need not remember the numbers, okay? They are 2 to 9 millimeter in size. That means they are multiple small. So when you get multiple follicles, small follicle, and in the periphery, that is our PCOS. And when you get big follicles, when we get big follicles, all in the, again, but big size, and along with this, as I said, if you get ascites, that is our OHSS. So don't get confused. I hope it's absolutely crystal clear. Don't make a mistake. So small follicles, chote follicles, periphery, mark it as PCOS. Big follicles along with ascites, and of course most important, history is history of ovulation induction treated for infertility, given for infertility, that is OHSS. It's a very important PYQ likely to be coming in the upcoming exams also for sure. Okay, so I wish all of you best of luck. Do not forget to subscribe to the OGGuru app, and under my guidance, please go for the masterclass FMGE 1 month duration, and under my guidance you are going to able to revise your entire OBGY within few days is my guarantee. Do call me, get in touch with me. I'm personally guiding all the students how to study, how to prepare, and you're going to get beautiful theory lectures, rapid revision, MCQ discussion videos. The handwritten notes are beautiful, notes are available, mock test, everything is available just in 798. And before your upcoming FMG, you will be able to master OBGY is my guarantee. So do install the app and get in touch with me, and do not forget to hit the like button, subscribe to the channel, and get in touch with me, and share this video with all your friends. Best of luck.